Well, hello everybody, and welcome to CE Elevated, a CSU Vet CE webinar series. I'm your host, Ross Palmer from Colorado State University, and I'd like to thank you for joining us on behalf of CSU Vet CE here at the Translational Medicine Institute. As many of you know, we've named this webinar series CE Elevated, symbolic of our Colorado mountainous terrain, as well as our mission to provide you with an elevated experience in both our on-site and online continuing education. We believe there's great power in the collision between inspired learners, engaged educators, and meaningful experiences. Tonight, we're sincerely thankful for the support of the Veterinary Emergency Group, also known as VEG, who has made this webinar episode possible. Most importantly, I'd like to thank our speaker this evening and all of our webinar speakers for their contribution to this CSU Vet CE webinar series. Each speaker has volunteered their time with us, so we're very grateful to each of them for that, as this series wouldn't be possible without their generosity as well as their expertise. Tonight, we're joined by my friend and colleague, Dr. Rita Hanel, and we're excited to have Rita here with us. Rita is a graduate of the University of Florida College of Veterinary Medicine and has obtained specialty certification in both small animal internal medicine as well as emergency and critical care, as if one specialty board certification isn't enough. She has served as a professor at North Carolina State University's College of Veterinary Medicine. She's been the senior director with Blue Pearl Veterinary Partners, chief veterinary officer for the Gentle Care Animal Hospital Group in North Carolina, and director of consultation services for Antech Diagnostics. She currently serves as the Senior Director of Clinical Academy Programs for VEG, where she's privileged to pursue her passion of helping veterinarians be at their best when people and their pets need it most. She lives in Raleigh, North Carolina with her husband, Chris, children Sophia and Nate, and their fur babies, Sadie and Curacao the cat. So welcome, Rita. It is great to have you here at CE Elevated. Thanks for being with us tonight.
Thanks so much, Ross. I really appreciate the introduction. And hope everybody is wide awake. I know we have some different time zones here, so I appreciate you guys logging in after what was probably a pretty hectic day for you as well. Should we get started?
Yeah, go ahead and see what you can share with us.
All right. Okay. Well, thank you everybody for joining this evening. And I will admit, you probably heard a little bit in my background. I started with internal medicine, but my passion has always been emergency critical care. And so I migrated towards that and have continued in that vein, no pun intended, no pun intended. But I love emergency critical care. So this ABCs of Addison's talk does have a bit of a slant towards that. I've helped out with consultation and educating in several different groups now. And so you will see some themes, kind of things that I've placed in here are in tune with questions that I kind of get asked a lot and things that people stumble on. More with the acute Addisonian or the Addisonian crisis. So the focus is definitely more on that, although I'm happy to talk about chronic management as well, should that questions with that arise. So with that, we'll go ahead and just jump right in, okay? All right, so our objectives, what we're going to talk about tonight is briefly what is Addison's disease, and then how do we assess hydration, perfusion, and looking at blood volume. You're like, oh God, she's going to talk about fluid, but it tends to kind of feed in a lot to the treatment of hyponatremia, which is what I think a lot of the questions that I get asked center around. That's kind of the scary thing, right? Is the electrolyte disorders and how that partners with the issues related to perfusion, especially with the acute Addisonian. And then we'll talk a little bit about mineralo as well as glucocorticoid supplementation with the disease. Okay, so sorry, I'm just moving my pictures out of the way so I can see here. So we'll kind of have a case helping to guide us through this. So this is Tonka, who is a 2.5-year-old female sprayed mixed breed dog who is about 23, 24 kilos at presentation, and presents to us for vomiting of 1 day in duration, and looking back has had some kind of loose stool, progressed over small bowel diarrhea over the past couple of days. She's been lethargic and definitely worse today. So the owner kind of carried her in. She wasn't completely collapsed. She could stand. She was pretty weak. And definitely got a lot worse today. She's gotten into things a lot. So the owner thought this was just something related to maybe garbage gut. She's done that before, but then started to progressively get worse. So she brought her in today. So shockingly, we'll go ahead and just let the cat out of the bag. We're talking about Addison's. So guess what? This dog is going to end up Addisonian, right? Or is Addisonian. But let's kind of talk about how we assess her and how we go about treating Tonka. So real quickly, just to get the what is Addison's out of the way, as you guys know, Addison's disease is a disease in which we have atrophy of the cortex of the adrenal gland. Specifically, the most affected layers are going to be those providing mineralo as well as glucocorticoids. You can have atypical Addisonians that are primarily glucocorticoid. It's a bit more uncommon, but does occur. So we have some familial tendencies that we see as well. I've listed some breeds here for you. Standard poodles, Westies are big ones, and definitely some genetic tests are on the horizons for some of these different breeds as well. Again, usually seen in that middle-aged female spayed, and then typically related to the primary familial atrophy, but you can also see it with tumors or infarcts or cancers that invade the adrenal gland as well, and that's going to be more your aged population. So the signs that we see are related to the deficiencies of those hormones, right? So with mineralocorticoid deficiency, we're going to lose, if you remember, don't worry, I'm not going to go too deep here. If you can see my pointer, if we're looking down at the level of the end of that kind of renin-angiotensin aldosterone pathway, looking at aldosterone, the primary effect there is going to be on that exchange of the sodium and potassium. So you resorb sodium and you excrete potassium as one of the biggest mechanisms or effects of aldosterone. And the impact of that sodium reabsorption is with sodium goes water, right? Unabsorbed salt crystals, we absorb sodium and water goes along with that. So this is one of the primary mediators as a component of the RAS system of maintaining one's blood volume and hence perfusion. So when that goes awry, obviously as things progress and the animal's continuing to lose salt and water, we get decreased blood volume and potential circulatory collapse, which leads to the Addisonian crisis that we see, starting with pre-renal azotemia, as I have that poor perfusion, and then left unchecked, they can actually progress to injuring the kidneys if we don't get to our patients in time and able to restore perfusion there. Okay. And then on the glucocorticoid side, we talk about, if you think about the diabetic, the things that you look for that cause insulin resistance, right? Steroids being one of those things. So steroids have an impact on the sensitivity to the receptors in the pancreas to insulin. So when they're not present, you can have hypoglycemia as well. And then that classic lack of a stress leukogram. So glucocorticoids are part of the reason you have a stress leukogram with your high segmented neutrophils and monocytes, as well as lymphopenia and eosinopenia. So the reverse of that is often seen. And then these kind of vague GI signs related to perfusion and maintenance of mucosal barriers and things like that. Okay. So again, hyponatremia being, in my mind, one of the things that are the most scariest parts to deal with. And what I get asked about the most. So if we dig a little bit deeper into that, I'm going to do a little bit of physiology. So have a glass of water, stand up for a moment. I won't go too deep again, but just remember when you have a low sodium, you kind of think there's kind of three different big reasons for that. One is, could there be some sort of artifact? Like I have a lot of lipids there. I have something else that's interfering with the machine's ability to measure it properly because it's not judging the amount of plasma that's there properly. Or do I have something that's artifactually lowering it because it's pulling excess water into the bloodstream? So we see this with hyperosmolar diabetics, right? That glucose pulls more water and it actually dilutes out the sodium, okay? So in both these cases, the sodium in the body is not actually low. It's either being measured inappropriately over here on this normal side, or it's just being diluted out because I have this extra solute there that's drawing extra water in, which is usually sodium's job. And then we have this category, which is where your Addisonian falls in, is your hypotonic, hyponatremic patient. And then those fall into three different categories, right? Euvolemic, which is weird syndromes that we see a lot more in people than we do in animals, like SIADH, but it does happen on occasion, hypothyroidism, psychogenic disorders. And then we do have hypervolemic states that we see, right? So those are patients that have what we call a decreased effective circulating volume, meaning like congestive heart failure or liver disease when you have ascites. So your body is overloaded, but your blood is not circulating well. So in essence, you're hypervolemic. But most commonly what we see, and what we see in this scenario, is the hypovolemic, hyponatremic patient, okay? And specifically when we're talking about Addison's, a lot of that reason is, again, I can't resorb that, so I'm peeing sodium, and there goes all my water with it, and so I become hypovolemic in the face of that. And hopefully it'll become more obvious. I'll go through this a little more as part of resuscitation. That'll help you to understand why why it's even important to take the time on an evening to go through that. So sorry, just going back here. So the different reasons that you could end up with hypovolemia and hyponatremia is going to be Addison's, like we just talked about. But if you block aldosterone in some other way with drugs like ACE inhibitors, or you're giving a diuretic, or the kidneys are malfunctioning. So the big things when I'm thinking about differentials of this hypovolemic collapse, hyponatremic patient come in is, could it be Addison's disease, especially if the shoe fits with breed and signal? Could it be GI disease? We sometimes see that happen as well. Whipworms, we call those pseudo-Addisonians, pregnancy, some weird physiology there, but that contributes to that. Or I have injury to the kidney like AKI, or I have a toxicity or some sort of drug that's, again, interfering like an ACE inhibitor. And luckily now, point of care methodology, we're able to run like a basal cortisol. So we can pretty easily sort these things out. It was before we had until everything came back in the lab and we were treating based on our gut. Haha, pun intended. Okay, hope you guys are still with me. But yeah, so now we can run a basal cortisol, and that has to sort it a lot for us while we're in the hospital. So I'm not going to go through this algorithm, but basically, obviously, the test of choice is an ACTH stimulation. And even in the face of that basal cortisol, I do still recommend the full stim. I typically, even in an emergency setting, send that off to a lab so I get those accurate values. And so I'll usually run a basal cortisol in clinic. And if the shoe fits and everything else, then I do my store those two samples to send off to the lab as soon as that's available. So when you're looking at that basal cortisol, just a reminder, what's kind of cut off there. I said, if the fits, looking at the segment that we just went through, and does the dog have the correct signs? And then I run basal cortisol, and if it's less than 0.5, that's about 99% specific. This is one study that I'm here of over 200 dogs, of which they did stims on for various reasons, about 14 of which were Addisonians. And by far and away, the majority of them had a cortisol of less than 1. And if it's less than 0.5, really high specificity, so pretty darn sure. There were a couple patients, though, that were in that 1 to 2 range and really needed to do the post in order to sort that out. If you have a basal cortisol above 2, it's highly unlikely that that patient is Addisonian. Really nice for a side test. If it's greater than 2, highly unlikely. If it's less than 0.5 or 1 and all the signs fit, highly likely. Again, I still do the full test. Between 1 and 2, little equivocal. I'm going to look at the rest of what's going on and probably still treatable, so to speak. But I'm going to really rely on that ACTH to come back and kind of confirm it for me. Or sorry, ACTH stimulation. Okay. So let's get back to talk a bit then and say, okay, evaluate talk in the face of all of these things that I'm talking about. So how to approach the Addisonian when first come in? Well, the same way I approach every patient when they come, and what I mean by that is I think an emergency standard, it's really great to kind of a standard that you approach things, because it makes it a lot easier to be able to identify when something is wrong. So the same way we do this all the time when we read radiograph, right? So we always put the head to the left, the tail to the right, the spine is at the top, and then I'm able to identify and things out to me more when they're wrong. We've started exercising this as well with recover guidelines and standardizing CPR. And so I would advocate when you have a patient who's quote unquote collapsed, if you take the standardized approach, because it's a stressful thing to figure it out and have to treat it and all these things, trying to think through the potentials and to treat the patient at the same time. And if you kind of take a standard approach with your team and get your team a standardized way of doing it, it's going to feel more like reading a radiograph to you, and you'll be able to figure out what's going on, know how to monitor it, and treat as you go. So my standard approach to the patient is that I teach called Fluids and Cope. And basically what that stands for is when the comes in crashed, I want fluid, because the majority of shock responds to fluids unless it's radiogenic. I want my crash cart there. I'm going to put oxygen on the patient, get their pulse ox before and after till I find out whether there's something going on in their lungs. I want my POCUS there, my care ultrasound, which when I ask now, when I'm lecturing at large scale venues, does seem that the majority of practitioners have it available to them. That's super, super great. And then EKG, but obviously I'm not just using the EKG. Like I said, the pulse ox and blood pressure and stuff just reminds me to grab the EKG machine and wheel it over there. And so I'm doing my physical exam, obtaining my vitals. And as a standard, I'm putting the EKG on to help me assess that initial rate and rhythm, as well as its response to my efforts. When I put the catheter in, teaching the nurses with me to always grab that little bit of blood and do my big four. My crash cart's ready, my flow by, my pulse ox, looking at it on and off oxygen. And when I do all these things together, I can pretty rapidly figure out what's going on with my patient. Okay, so let's do some fluid cope with Tonka. So overall, when Tonka comes in, she has kind of dull medication, about 8 to 10% dehydrated. Her temp is 98 Fahrenheit. Her pulse rate is 54. Her respiratory rate is 42. She's pale, a CRT, full 2 seconds. Her heart and pulse, though, sound pretty clear, no murmurs or anything like that. Her pulse quality leaves a little bit desired, kind of hypodynamic, but they are synchronous and I can feel her pulses. In general, her belly feels a little gassy. There's nothing distinct or overt. She's kind of generally a little bit uncomfortable, and some gas there. And on rectal, it's clean, but she does have diarrhea. So again, on neuro exam, because she was dull, I just like to always take a quick check, and her pupils do respond and are symmetrical, and there's no real cranial nerve deficit. I think it's more related to systemic disease. And now I'm doing my fluids and copes. I have my fluids ready, and just noting for you again, I was saying, so 98. When I look at a heart rate of 54, so again, we go back to pattern recognition. What's wrong here? You look at this. As I list all these other things, 98, pale, 2 seconds, Doppler's 90, pulses are, you're like, yeah, sounds like a shocky patient, right? But 54, that's like ding, ding, right? Alarm is going off. 54 is completely inappropriate for a patient that's in shock. My body, if it's trying to save itself, which usually it is, should respond to tachycardia. And so the top 3 things that always, boom, jump to the top of my mind, have an animal that's inappropriately bradycardic in the face of poor perfusion, is hyperkalemia, causing or impacting the electrophysiology of the heart. Do I have an AV block, or am I dying? Well, not me, right? The patient, meaning you've probably often seen, even with big dogs, that unfortunately, when they're getting to that stage where they may pass, they'll often vagal. Sometimes they'll retch, but they'll brady down. But clearly, Tonka does not look like that. So my big concerns are hyperkalemia, or do I have some sort of AV block? This is actually her EKG strip, which isn't overwhelming. She still does have P waves here. This is at about 25, and so her QRS maybe it's a little bit on the generous side, and her T's are a little bit pointy there. Okay, so mostly concerning me for hyperkalemia here based on presentation and what I'm seeing her EKG. So like I said, Doppler is about 90. Her pulses don't feel so great. So wrapping in my POCUS exam, and we're going to talk about this a little more in the ensuing slides, but what do I do with my POCUS? I always, in all my patients, I check the lungs, look to see. She has an occasional B lung here and there. I'll talk about what that is if you don't know. So it's intermittent, no pleural fluid, no abdominal fluid. Her LEAO is at the low end of normal, ratio of her left atrium to her area. Her end-diastolic diameter, which is how big her heart is, how robust it is in the end diastole when it should be most full, actually a bit small for a dog her size, be about 4, and no fluid seen in her abdomen. And then I could kind of scan over when I'm looking at her belly and look at her caudal vena cava, and it's kind of flat too, which and it's not really, robust and bouncy like we see with an animal that has appropriate volume circulating through its system. So I did not have yet, and actually something happened. Is looking back at her records, I found her post resuscitation lactate, but did not have her. But I'm guessing that it was like high. This is her case, and her PCV total size was 62 and 7.4 point of care glucose of 55. Okay. Overall, now I'm able to, with my fluids and cope. Okay. If I think about the different things that make a dog go into shock or collapse, cardiogenic. Nope, I know that's not the case. I looked at her heart and it's actually small and her lung fields are good and she doesn't clinically look like that. She doesn't look like an obstructive shock with GP or anything like that. She does not appear to be septic. And so I'm pretty darn confident that she's in hypovolemic shock. And I've got a good base to measure against my resuscitation. So she's in hypovolemic shock. She's dehydrated. I'm suspicious based on her rate and looking at her EKG that she's hyperkalemic. And I'm concerned that could be hypoglycemic there. Her crit's a little high, so it can sometimes mess with point of care glucometers. So I'm getting a chemistry panel. I'm going to want that to confirm it, but I would go ahead and treat based on that anyways, because she does have altered mentation as well. So my next steps, I don't even have blood work yet. I'm asking for that, but I have this patient who's kind of crashed out. And I do have evidence that she would benefit from fluids. So I'm going to give an LRS bolus. I usually start with 20 ml per kilo, and then I do subsequent 10s to effect. I'm going to give her some calcium gluconate and perhaps an albuterol puff as well, especially once I have my blood work. We'll talk about why, if you probably already know though. A dextrose bolus, finishing up that scan while I'm doing this, and then kind of putting a little bit of haste on that blood work in the queue and saying, hey guys, I think I need a basal cortisol for this patient. Okay. So let me pause there for a moment. So I know I jumped right into the meat of things, and just see if there's any questions there yet, Ross.
So thanks, Rita. Yeah, boy, this is great information, even for an orthopedist. Actually, especially for an orthopedist. I did see that for the euvolemic hyponatremic patient, one of the rule outs is beer potomania, and I think I may fall victim to that sometime soon. Now, my question is you mentioned giving calcium. Is there a downside to giving calcium if you're wrong and it really isn't hyperkalemia at this stage?
Yeah, that's a great question. And I would say for the majority of patients, or in general, no. You can increase the eyes by 0.1, 0.2, but you're usually not going to have any sort of clinical effect. It's more about stabilizing and kind of bathing those cardiac myocytes and getting that threshold potential up a little bit more. And so if they are suffering, meaning that the heart rate is low, if I see outward cardiovascular signs related to it and my blood work isn't hand, I'm going to go ahead and treat for the triple and give the calcium, and have never had untoward effects as a result of that. Great question.
Yeah. I'll tell you what, it's such good content. Why don't we jump right back in? One thing I did notice, occasionally there's a little bit of a choppiness in the audio, so maybe we both shut off our cameras to decrease the bandwidth demand. We'll see if that helps our audio, and then when we do the next Q&A, we'll both turn our cameras back on. How's that sound?
Sounds great.
All right. Thanks.
Okay, let's keep going. So I've started to talk a lot about hydration versus perfusion, right? And how that's kind of key to figuring and treating these cases. So hydration, you guys all know this: skin turgor, eyes, and tacky mucous membranes. And then looking if they're overhydrated, we can look at the skin, the eyes, but just calling out with that exam, part of the reason that I incorporate that into my baseline is as patients get overhydrated, remember that the lungs can get edematous just like anything else in the body. And if I have leaky vessels or something like that, say with sepsis, then they're even more prone, or with pulmonary contusions or something else. So I like to, in any patient that I'm fluid resuscitating, just keep an eye on those lungs. And I use B lines if they're increasing as a way for me to know I've got leaky lungs and I could get myself into trouble here before they get into distress. But a big call out here is USG body weight. So especially with the Addisonian, USG, again, my aldosterone is messed up. If your kidneys are messed up, you're not able to monitor that USG very well, but body weight for sure. You are 60% water, a dog is 60% water. And so when you're fluid resuscitating, it's important to make sure, especially if you have an animal with lots of losses, like an Addisonian, you need to make sure that you're keeping up. Okay. So obtain that body weight, and I'll use that as part of my serial measurements. Okay. All right. So just to show you what B lines are, so here's kind of a normal here. I'm looking at a lung ultrasound. Here's a rib head. Here's a rib head. Normally, air blocks the ability of ultrasound waves to traverse. So I kind of get nothingness here. Whereas if there's any sort of fluid, it could be blood, pus, or edema. So you have to look at it situationally. Is it pneumonia? Is it pulmonary contusions? Or is it excess fluid in the lungs from fluid overload? Then I'll start to get these streaks. And so this is actually a dog that's hit by car, so it's contusions, but you get a lot of these streaks that are between the ribs like that. Okay. And perfusion is different, right? So I'm looking at the color, the capillary refill, the temperature, the pulse quality. Are they making urine? And then again, I can use that POCUS for a little bit more objective guidelines. So is my heart nice and robust and full? How does my left aorta or left atrium to aorta look? And especially in a patient with a heart murmur, that's unrelated. They're not in heart failure, but also need to know when I'm pushing too far with the fluids. If that LAA is quite big, it worries me a little more. And then that cardiovascular distensibility. So let's talk about that a little bit. Okay. So how does my patient look, and what am I looking? I told you I did 20 mLs per kilo and 10 ml per kilo boluses subsequently to effect. So I'm wanting to reverse any of the signs that I'm seeing telling me that the body is suffering from poor perfusion. So what are those signs? As the heart is beating and pumping blood to all of the organs, ignore the amounts here because this is a human chart, but the percentages are quite accurate. Your body is going to do everything it can when it's in trouble to save circulation to the core important organs, the heart, the brain, the lungs, your central circulation. So what it does, you go into shock if it's able to control itself, which in most cases it can, except for sepsis. Then it's going to constrict to areas that are less important to send blood toward things that are important. So if you were to add up these percentages, I shift blood from areas that are peripheral, so muscle, skin. So you get cold and clammy. You watch videos. Oh, I feel cold and clammy. You're like, that's because you're dying. So you're going to shift blood from areas lesser important, also including that liver and digestive tract. And if you add up these percents, you see it's pretty cool. Your body can actually shift like 50% of its blood volume by kind of depriving some organs of blood flow, in order to, again, maximize that blood flow to the heart and brain to try to stay alive during this flight or fight response. And this is the reason why when you resuscitate, we use that term shock gut. After you've given animal a bunch of fluids, I was in shock, they kind of finally get up and then blow out a bunch of bloody mucoid diarrhea. And that's a consequence of the GI tract being deprived of some blood for a little bit of time. Okay. So again, as I have that decreased blood volume, I have less blood volume, and I'm starting to get that pale appearance. My heart's going to beat harder, and it's going to beat faster. My body starts to make choices, and it says my gums, my rectum, okay, which is the periphery of my GI tract. These things are not as important when I'm in trouble. I need to save my core. My feet also get cold. Okay. And when I look at that pulse quality, it's not as robust. Okay. I have epinephrine and norepinephrine, which even in the Addisonians still do work. Okay. Cortex is not working. But the center of it still is, okay? And so I can still affect and have some change on that vascular tone there, right? So the hypovolemic patient classically is going to look exactly as we described with Tonka, except for she had that low heart rate suffering because of the hyperkalemia. So we're going to start with LRS. I have my crash cart ready. I'm giving her oxygen. We've described what we found on her POCUS exam. Her heart is small, and her cava is overly collapsed, and she's bradycardic. So that EDD, just a shout out here showing you what that is. You can look and see how full is the heart, and I can measure that end diastolic diameter. So it's just a line I'm drawing right here or right here in this mushroom view and say, how big is it? And then I'm looking at my left atrium to aorta. So as you become more proficient, if you really enjoy ultrasound, it can really help you out in so many ways. When we talk about the cava, remember that veins are a low pressure system. So usually it's sitting at like 5 millimeters of mercury versus like, 100, 120 when you're talking about the arterial system. So as your blood pressure, as you get hypovolemic, the venous side is very susceptible to things as subtle as even breathing. Okay. So when I take a breath and I cause positive, well, in this case, if the patient's ventilated, it's positive pressure. If I'm spontaneously breathing, negative. But those pressure fluctuations of just breathing, if you're hypovolemic, can collapse your cava. Whereas normally it puts a dent in it, so to speak, but less than 50% of a dent. Okay. I can't cause a big dent if it's full, like it should be. So that's a really nice measure, and one that's a little bit more objective even than that EDD, okay, which can be impacted by heart disease. All right, so respiratory fluctuations in volume depleted animals are usually greater than 50%. So a pretty big dent, or they're flat. So this is, again, I just look at that gallbladder and I just pan a little bit more to the right, and you can pick up that cava right as it's crossing the diaphragm. This is one that's big. This is one that's really flat. So as I'm doing all this and confirming that she is hypovolemic and getting my LRF started, I get my blood work back on Tonka. So we can see here, glucose is 40. She's azotemic with a creatinine of 6.7 and a BUN of 96. Her sodium is 139 with a potassium of 9.7, making it really obvious why her EKG was so impacted with a sodium potassium ratio of 14. Okay, so some pretty classic lack of mineralocorticoid signs over here. Confirming what I knew from my PCV total solids, that I do have some volume contraction here. And then I just want to do a shout out here because so we do lack a stress leukogram. Okay. So the shout out is to just be weary. I know a lot of us, especially on emergency, we're busy, right? We look for the red, we look for the red, we look for the red. So if you just look for the abnormalities in the red, you would totally miss that this patient lacks a stress leukogram. Okay. Actually, try to tell edocs, when they're first starting out, if you have a sick patient hit your door and you don't have abnormalities in the CBC, you need to stop and pause, because normal is abnormal when you're really stressed and sick. Okay, so I should have some sort of stress leukogram there, and this patient does not, so that should draw your eye. Again, a great way to miss an atypical Addisonian, which would not have all of these other things potentially, and this would be your harbinger. All right, so don't just look for the red, look at the patient, look at the entire CBC, but especially the leucon. Okay, so we go back to Tonka and say, well, what did we do? I have this blood work now, so it gave more power to my push and reinforced what I was doing. So I'd given her 20 mLs per kilo to start, and then she actually did need 2 more 10 ml per kilo boluses. So she had a total of 1 liter of LRS. I gave her a dextrose bolus, 50% diluted. We gave her some calcium gluconate, slow, over about 5 minutes to effect. And then a couple puffs of albuterol as well. And then gave her some Dex SP and initiated her ACTH stimulation and asked for the, well, they were basically saving the rest of the blood from the basal cortisol, and then confirming with mom we could give an ACTH for the full stim. So we know what Addison's disease is. We've talked about hydration, perfusion. I want to touch on one more thing with blood volume combined with hyponatremia and hyperkalemia. So hyperkalemia, hopefully you guys probably familiar, right? Classic black cat. So you guys have probably seen hyperkalemia mostly in those instances, sometimes AKI, and unfortunately sometimes with an Addisonian, right? But super fun. It's always great when you have fixable things that are rapidly fixable. So in the instance of an Addisonian, I just want to have one watch out for you guys, is that I usually give glucose, and then I'll give a beta agonist like an albuterol puff. And I only give insulin if I need to. And the reason is because, remember, without that glucocorticoid, my receptors are super sensitive to insulin. So I would definitely never give insulin unless I had actually gone from not just a bolus, but confirmed the glucose was high and put glucose into the fluids. okay, so that I have glucose going while that insulin starts to kick in. So not just a single bolus. So they're going to be overtly sensitive to that insulin. So just take a little caution. And I would say in the majority of patients, I can get where I need to go with a bolus of glucose, which does actually stimulate endogenous insulin if you give enough, which is why I'll go that upper end sometimes of 1 ml per kilo. If you give enough to make them hyperglycemic, you will get some endogenous insulin as well as the beta agonist. So usually gets me where I need to go. I try to shy away from sodium bicarb in Addisonian because the first part before the bicarb is the word sodium. This patient, not too bad. My sodium is in the 130s, but if you have a very hyponatremic patient, you're giving a sodium load there. And so that could be detrimental. So little tip and trick, glucose bolus, high end beta agonist, no sodium bicarb, only insulin if refractory and on a CRI. Okay. So here's Tonka after she got her resuscitation. So she's now resuscitated, and they're still giving some calcium there. She got a little bit nauseous there. So, actually that might be her glucose bolus, apologies. So she got her albuterol puff, she got her calcium, and there she's getting her dextrose bolus, apologies. So looking a whole lot better. And then we get that baseline cortisol back. And in fact, she has all the classic signs and the classic blood work, and it did come back as less than 0.5. So we gave her the ACTH and stored her stim to send out when the lab collected. So let me pause there before I go into the fun with sodium part and see if there's any other questions.
Yeah, I don't have any questions from the Q&A window. I don't know if you want to talk about dexamethasone and the ACTH stem test. Is that something we should bring up at this point, or should we wait till the end? How do you feel
No,
about
that's
that?
fine. I can actually mention that now. Yeah. So I get asked that a lot. And so if you give, the question is dexamethasone, usually what I get asked is dexamethasone doesn't interfere with the ACTH, right? So I can go ahead with the stim and do the ACTH later, tomorrow or the next day, depending on what mom decides. It's no big deal. So when they say dexamethasone doesn't interfere with your stim, what they mean is that it doesn't register on the assay as cortisol versus like methylpred or solu-delta or something like that. So it won't register on the assay. You're still impacting the adrenal axis and you still decrease ACTH. Usually, you're giving an ACTH slam on top of it. And so it's not going to have a profound effect. But if you continue and you wait till the next day to do it, you might push yourself towards equivocal results. So, the only expense is that you are giving the ACTH. Otherwise, just store it. And then if parents change their mind or things don't go well, you don't have to turn the stim in. And you can hold on those results. But I do think it's worthwhile to still do it that day.
All right, good enough. Yeah, let's keep rolling. There's such good information. Let's see what you've got.
All right. Is the voice coming a little better?
Yeah, it seems to be doing better. So thank you.
Okay, great. I will turn this off again. Okay. So coming back, like we talked about before, when you're Addisonian, so we'll dig a little bit into that sodium part here. So when you're Addisonian, you're in that category of a hypovolemic, hyponatremic patient. And the reason you're that way is because you can't conserve sodium at all. So you're losing large amounts of sodium and water is going with that. Okay. So remember that one of the biggest ways that your body is able to maintain blood pressure is through the RAS system. And the end product of the RAS system is production of that aldosterone. Okay, so renin-angiotensin-aldosterone. I'm not sensing that I have good urine production and perfusion here. So aldosterone is then going to mediate that sodium and water retention, which gets taken out when I'm Addisonian. And so as my blood volume drops, the other thing that angiotensin does is it stimulates the posterior pituitary, okay? And so I get ADH released too, anti-diuretic hormone. So it makes me conserve free water, right? So, really ADH is built to fine tune the sodium level in your blood and your osmolality, but there is what's called the non-osmotic stimulus to ADH, which is a late response. But if I actually get hypotensive and I'm having significant sympathetic stimulation, then my ADH is going to kick in because the body always tries to save itself, right? It's an eloquent, amazing system. So if my aldosterone is defunct, ADH is my backup. Why am I taking the time to talk about this? Because just remember that I have two things at play. And so we focus a lot on treating the mineralocorticoid, but the ADH is the reason why resuscitation is so important, because I have to keep up with the sodium and fluid that I'm losing through the kidneys. But remember that my body is working against me. I want to bring my sodium back up. And if I don't stop and kick this ADH to the curb and stop my body from excessively retaining free water, my sodium is going to potentially go the other direction and go down. Okay. So here's the scary stuff. So I'll come back to that. So here's the scary stuff, right? Everyone's always like super worried when a patient comes in, because I don't want to cause his brain to turn into a raisin. So when I'm doing that initial resuscitation, like you saw with Tonka, I want to use a fluid that has a sodium content that's closest to the blood. So I want to resuscitate or restore euvolemia with a crystalloid that's close to whatever the blood is. And when I say close, I'm saying within 10 to 12 milliequivalents. So for Tonka, we got lucky. I would start, even if I suspect Addison's, I start without LRS. And then once I get the lights back, I adjust based on that. And so LRS has about 130 milliequivalents per liter of sodium. So let's say I have a patient, though, that is less than 120. So if it's in the 110 to 120 range, then I just do like a 90% of LRS. So I take 900 mLs of LRS and I use 100 mLs of D5W, which has no sodium. And now I've put it down nicely to 117, obviously sterilely, you know. And then if they're even lower, God forbid, it's rare, but on occasion you'll have the Addisonian that's in the 100 to 110 range. And then just take 800 mLs of LRS, 200 mLs of D5W, which is 80% of 130 at 104. So you don't need anything special to do it. You're just doing some pretty routine dilutions. And then I use that to bolus my patient. In Tonka's case, it took me a liter until I got her blood pressure good. I normalized her heart rate with treating her hyperkalemia. Her perfusion parameters were good. She sat up, she looked at me, she wagged her tail. And she didn't have, but you know, as you resuscitate, some dogs will have some diarrhea if their gut took a hit. So the goal with that resuscitation, though, is remember that part of the reason ADH kicks in is to save yourself when you're hypotensive like that. And so if I adequately resuscitate the patient, I can turn off that ADH, which is driving me to retain free water. So I need to resuscitate to shut down ADH, and then I can more effectively give sodium and control things a little bit more with my replacement and ongoing finishing of my resuscitation. Okay. So in general, I would say, you know, I'm going to go through a sodium calculation with you here to be academic, so to speak. But if sodium is, just to show you and then tell you why you don't have to do it, but if sodium is over 120, I just give them LRS and don't worry about it. Don't stress about it. You know, it's 130. So I'm within 10 points of what the dog's sodium is. So if it's 120 or over, resuscitate them with LRS. Then you can figure out their maintenance plus dehydration and just put them on LRS. If the sodium is rising too fast, then I might cut it in half and give half LRS and half 0.45%, so half strength sodium chloride. And then I adjust it in quarter increments, which I'll show you. If the sodium is less than 120, that's when you have to worry a little bit more. Okay, so let's look at Tonka here for a minute. Okay, so with Tonka, her sodium, I got really lucky, is at 139, lucky from the standpoint that it's over 120. And so we were able to resuscitate her with LRS. We already talked about her albuterol or dextrose, all of these things. So once we put her on fluids, we actually use completely LRS. So her maintenance is at 1.4 liters and her resuscitation or her replacement is also at 1.4 liters. So 1.4 liters and then an additional 1.4 liters for her replacement. And so that's a total of 3 liters given over 24 hours is 120. We give her Dex SP at 0.1 mg per kg, IV BID, Serenia because she was a little bit irpy like you saw. And then once we had her baseline cortisol, we started her on DOCP. So she was actually pretty routine. Okay, but let's say that wasn't Tonka's blood work. I have some other blood work for you. And let's talk about what we do if it's less than 120, okay? Here's, again, to be academic, but these are the equations that I use when I gave you that 1.4 for maintenance fluid rates for the dog and cat. All right, so for a dog, and this is by AHA guidelines as well, 132 by body weight to the 0.75, or you can use the 40 to 60 mLs per kilo per day if you're more comfortable, okay? And usually we can equate resting energy rates to the amount of water a dog needs, because dogs are a 1-to-1 ratio. But actually, if you look at the requirements, like how much sodium a dog needs in a day, they actually only need 1 milliequivalent per kilo per day, because they're so good at retaining sodium. If they need it, they really only need exogenous at a very low level, 1 milliequivalent per kilo per day. So classic true maintenance fluid would be like half strength sodium chloride, okay? Titrated KCl for, like everyone has their little amount of potassium they add based on what the dog's potassium is. And then you can put magnesium in there if you want to as well, if they need it. And that is actually a classic maintenance fluid. And you say, well, so what does that look like for Tonka? Well, that means that Tonka would need about 24 milliequivalents. That's really all she needs in a day of sodium for us to give her to live and walk around, and what she needs in her dog food and everything else. So what about when we give LRS? So at a maintenance rate, we talked about she gets 1.4 liters per day. Well, 1.4 liters times 130 milliequivalents per liter is 182 milliequivalents of sodium, okay? So is that a problem, right? We do that all the time. Am I telling you that you shouldn't give LRS to dogs? The answer is no. But just consider that when you give her LRS in a maintenance fluid cocktail, you're giving her about 7 times the amount of sodium she needs. So it's like you or I put some soy sauce on our food, or we had some potato chips. If your kidneys and your heart are fine, it's really not a big deal, okay? It's more of a big deal if you have a heart patient or a kidney patient. But just wanting to make you realize that a dog, even like Tonka, only needs 24 milliequivalents of sodium. So then when you look at Addison's and hyponatremic disorders, there's a lot of calculations that you can do. And so what we say is you can look at the total body water, and you're going to multiply that times the desired serum sodium you want minus the actual serum sodium, okay? Now, the problem with this equation, it assumes that the dog is a fixed box, okay? Dogs don't live in a box without anything coming in and going out. So that's why I'm going to tell you, I'll show you the equation so that you know, and then I'll show you what I typically do in real life. So again, there's the dog in the box, and what this equation is saying is if I have this much water in a box, how much sodium do I need to put into that box of water to change the concentration of sodium in the box? But we know that dogs drink, we know that they're peeing, and so it's not a fixed box. But let's just go ahead and do it. So sodium, let's say Tonka sodium is 116 and the potassium is 7.12. So this is blood work from another Addisonian patient. So we'll apply it to Tonka though. And if I wanted to increase her sodium a safe rate, so the max is 12, I usually target 8 when I do these calculations just to double check myself. So her total body water times my desired change of 8 in one day, the difference between what I want and what she is. So like I said, the body's 60% water, 0.6 times 23.6 times that change of 8 tells me I have a deficit of about 113 milliequivalents of sodium. I'll throw her maintenance on there. She needs about 24. So really the grand total that she actually needs over 24 hours is 137 milliequivalents of sodium. Okay, assuming she's in a box. She's not in a box. Then if I go ahead and say, all right, she's still dehydrated, I did resuscitate her, I'm going to put her at about 6% dehydration. That's another 1.4 liters. So my total fluid needs for Tonka are 3 liters. And I want to give her about 137 milliequivalents of sodium. All right. So that's my target. That's what I want if she was in a box. So if I give her LRS and I give her a full, all that 3 liters, like I actually did do with Tonka, times 130, that's 390 milliequivalents of sodium, about 3 times the amount of sodium that she needs. If I give it as 0.45% sodium chloride, which only has 77, then that's about 231, so a little bit closer. The reason that I do this is a lot of times people think, well, I need to give 0.9% sodium because she's down so much sodium, okay? But that sodium's redistributing throughout all of the water. And so you can see what she actually needs is much less than that, and you can actually get her where she needs, even with a half strength fluid, which sometimes doesn't make sense. I'm mixing solutions in a box. You don't make the whole body shift to what is contained in the fluid. I'm mixing salt and water in a box, and everything is redistributing. Okay, now what do I do in real life? Because as I said, the dog is not in a box. So what I often do is these equations for funsies, and then I turn around and say, okay, reality check is I'm going to put her on, I'm going to figure out that maintenance rate and give her that as 0.45%. And then I'm going to give that replacement as LRS, essentially 50-50. And this is when they're hyponatremic enough that they worry me. So what this would look like in Tonka, if this was her blood work at 116, is I would give her LRS at 60 and I would give her half strength at 60. And then I would recheck her lights in 2 hours. And if it's coming up too quickly, then I'm going to shift it by about a quarter. So I am going to go ahead and cut the LRS in half to 30 and increase my 0.45 to 90. I'll check it again in another 2 hours. It's still coming up too fast. Okay. And here's the rate. Never change more than 0.45. Okay. Or 12 milliequivalents in a single day. So if you check it in 2 hours, it should only go up by about 1. If you check it in 4 hours, by about 2. Okay. So if it all of a sudden jumps 3 or 4, then I'm just going to adjust these. All right. That's simple. If it's not coming up at all, and especially if it's going down, then again, I can adjust it the other direction. But first I double check myself to make sure, did I get that little bugger ADH to turn off? So I want to make sure that she has not lost body weight. And if she's peeing gangbusters, and you'll know it because again, you're in the first several hours. So you're seeing her, if your texts are saying, man, she's flooding the cage, then she might actually be peeing out more than you're putting in. And so it's going down because that little ADH is still kicking in and making her conserve excess water relative to sodium. So make sure that you're putting in an excess of what's coming out, or you will get behind and chase your own tail, pun intended. And I've had ones bad enough that I've had to put a UCAF in before, but those are like the 104, 105 sodiums that are a bit scary. And so I'm watching them more closely. So depending on how sick they are, I'm checking lights every 2 to 4 hours. If they're like the original Tonka where they're over 120, then maybe every 4 to 6 hours, just in that first 24 hours, but make sure the body weight is maintained and actually increases because my input needs to exceed my output or I will get farther and farther behind. All right. Okay. So this is just, if you like to screenshot, I'll have a slide after this that has everything from the whole talk in it, but this basically summarizes what I said. So you're going to resuscitate. Here's the different amounts of sodium and LRS and where you get to if you dilute it with D5W. If the patient is over 120, I just give LRS. If they're under, then again, you can do half and half and adjust it accordingly really easily based on what it's doing. So Tonka did fantastic. You saw our original sodium was 139 with a potassium of 9.7. Actually, as we were initially, this is post her albuterol and dextrose. We were still resuscitating. Her potassium came down. Her sodium actually went down a little, but we still just held with LRS. And then it continued to go up and her lights improved, as did her chemistry panel. So you can see here, very azotemic. She went home approximately 48 hours later with blood work that was pretty much normal at that point. And then we did get back her pre and post cortisol. And you can see both were actually less than 0.2 from the lab. So last step is that mineralo and glucocorticoid, and you have a couple of different options. So as you saw, I usually give Dex SP. Again, like we talked about, doesn't interfere much with that ACTH. And I just multiply whatever my Dex is times 8. I'm a person that thinks of everything in terms of prednisone dosages. So Dex is about 8 times as potent as prednisone. So I just multiply by 8. So if I give 0.1 mg per kg, that's like 0.8, so almost 1 mg per kg. And then I usually start out BID on that first stress day and then go to SID and then down to a physiologic rate, and they go home on prednisone. If you have DOCP, most general practitioners do. Some emergency clinics don't keep it on the shelf just due to lack of using it frequently, and they often transfer back to the general practitioner. But remember, it's primarily a mineralocorticoid, usually given once every 21 to 28 days based on their response in electrolytes. And you still will need, typically in the majority of patients, to give a glucocorticoid like prednisone because there's not glucocorticoid contained within that. You can, if you don't want to carry DOCP and you're an emergency hospital and maybe you're worried about the 3-day weekend or something where you can't transfer to the veterinarian, to their regular veterinarian for a DOCP injection, you can also carry Florinef, old school, or fludrocortisone. It's a daily pill. You can split it. I usually give it twice a day, the total dose. And it does have a little bit of glucocorticoid. Most patients, at least 50% or more, still need a little additional glucocorticoid, but know that there is a little bit of glucocorticoid along with the mineralocorticoid in that. And so you have to play with that a little bit more and check their lights weekly. Usually I'm just using it, or if I'm really not sure, it's that dog that had a basal cortisol of 1.9 or something, and I'm not positive, I might just give them Florinef until I get back the full panel, instead of popping them with DOCP, which is going to hang out for 3 weeks. Okay, so here is the MIST, or the most important slide. So feel free, if you're a screenshotter, you can take a screenshot. And it basically summarizes all the points of everything we just talked about in the stabilization of the Addisonian, and hopefully getting them home happy and healthy. So huge shout out to Dr. Alexa Gonzalez, who was actually the primary on Amazing Tonka, and did a fantastic job. So thank you for your time. And if anybody has any questions, I would be happy to address them.
Yeah, we got a couple of questions here. One is, do you ever give DOCP right away?
Yeah, so I do get asked that a lot, especially from emergency doctors. And is there a concern, again, going back to that, if I don't have that ACTH stim and it's coming back several days later, what's the downside of giving it? Probably mostly just the expense. It is expensive to give that injection, but again, if it's a 3-day weekend and you don't have a lot of choice, you could go ahead and give it if you're feeling pretty confident on that basal. But the other thing is just really, as far as any downsides, it does cause sodium retention. So if you were wrong, probably the only time you're going to get into trouble is, let's say it is a dog that has underlying mitral valve disease or something like that. You basically just gave him a bunch of soy sauce, or so he retained a bit more sodium than he needed to if he was not actually, or she was not actually Addisonian. So in general, it's a pretty decently safe drug, but you could get into trouble if it has underlying heart disease.
Got another question for you. I don't know if we've got just a couple of minutes left. You tell me whether we can tackle this one in the time. Otherwise, I'll twist your arm to get you back. We've talked about more typical Addisonian patients. How about some of the more atypical Addisonian cases? Can you address those in a bullet point or two? Or
Absolutely,
okay,
absolutely.
Yep.
And that's where I did that shout out, right? So the atypical Addisonian is not going to have the classic electrolyte disorders that you see. And so the classic things that I see are they still have all the GI signs. They come in with similar signs, GI, vague, right? The great imitators, but you're going to lack that stress leukogram. So that's where I did that shout out of, when I have a patient who's sick and not doing well, especially with vague GI signs, especially if they wax and wane, and I'm lacking a stress leukogram, then that's a big one for me. That makes me look at that basal cortisol for sure. And then the treatment is otherwise, similar. They usually don't have the electrolyte disturbances. And so I'm just treating them for any hypovolemia if there was a lot of vomiting or anything like that. And then they just need steroids. Yeah, for sure. And I would recommend that you check the lights on those patients, because some will still progress to a full-blown Addisonian. So I usually get them in every 3 months in that first year to see if they're actually going to stop with just atypical, because many of them can progress to typical.
Great information, Rita. I want to thank you. I mean, it is very evident the amount of in the trenches expertise that you have with the management of these Addisonian patients. For those of you who are tracking as fast as she is moving, I tip my hat. For those of you who are like, wow, there's a lot of good stuff there, but I didn't get it all. Again, it's recorded. It's available at csuvetse.com, so you'll be able to take that in. I know I speak for everybody in attendance that your expertise and your passion for this topic are greatly appreciated, very apparent, and I certainly appreciate your willingness to contribute to this webinar series. So thank you so much this evening, Rita.
Absolutely. Love emergency medicine. And I have my email up there at the top. So if anybody has other questions, feel free to send me an email as well. So thank you guys and good luck. Save those Addisonians. They're so much fun.
Yeah, thank you. So a special thanks as well to VEG for sponsoring this particular webinar episode. Dr. Hanel and colleagues, they do lead a number of different training courses designed exclusively for the new ER docs, the so-called nerds of the veterinary emergency group here at CSU throughout the year. Much as we do with VEG, we also do private courses that are custom designed to the specific needs of other private practice group networks. In addition, we offer dozens and dozens of specially designed hands-on training courses available and open to any veterinary professional. So you can check out all of those opportunities on our newly designed website at www.csuvetse.com. Once again, I'd like to thank all of you for joining us this evening. Next month, we're going to learn about tuning up your everyday orthopedic skills. And that particular episode will focus upon slings, bandages, and splints as critical tools in your trauma first aid toolkit. I'll have the honor of presenting that particular episode on Wednesday, September 7th at 7 p.m. New York time. That's 5 p.m. here in the mountains, and we'll look forward to seeing you all then. In the meantime, do remember you are more than a learner. You're a whole person. Take care of yourself, and let's look out for each other. Have a great evening, everybody.